So hopefully at this point, you've got a better idea of how to choose between the NRTIs when going through patient cases. As a quick overview, generally speaking, you're going to be looking for either reasons not to use abacavir or reasons not to use tenofovir. And because they come in single or kind of combination medications, if somebody's using tenofovir as one of their drugs, you wind up combining that with emtricitabine. And because it's also a co-formulation, if somebody is on abacavir, they're most often going to be put on lamivudine as well because it's co-formulated. And now we're going to start talking about how to choose a third agent. So in all cases, we have to consider their adherence and how likely they are to be adherent to their third agent. We want to go for those that are most forgiving or those that have high genetic barriers to resistance. And these tend to be boosted protease inhibitors, with the one exception of Atazanavir, which we will talk about, and Dolutegravir and Bictegravir. We also have to consider those that are easiest for our patients to take, and those will be single tablet regimens where all three medications are just in one pill. There are many single tablet regimens available. Most of them do have a third agent that has a lower genetic barrier to resistance, coming mostly from the NNRTI class. And while we will go over those just for people who are interested, those will not be on the test, or I will not hold you responsible for those because they're not considered as first-line drugs in treatment of HIV according to the current guidelines. The meaning here is that if you're going to be starting somebody on a drug that is a single tablet regimen that has a lower genetic barrier to resistance, be careful in non-adherent patients, and it might even be worthwhile to be careful in those that you don't yet know. And like I said, guidelines do suggest attempting integrase inhibitors as first choice, so we will start there. So all integrase inhibitors will potentially increase your CPK levels, your creatine phosphokinase levels. And in most cases, this is going to be asymptomatic, but you can actually use this information indirectly by starting with your members or your patients, getting them a CPK level, and then after they've been on it, it's almost guaranteed that that CPK will rise. So if somebody does come through and they swear they're taking their medications appropriately and you check their CPK level and it's just like it was at baseline, it's a good bet that they're not taking it as appropriately as they think they are. One other concern is that we do need to be careful with other drugs that a person might be taking that have the same increase in CPK levels. And as examples, the most common is probably the statins that can cause myopathy and rhabdomyolysis, but also consider drugs that our patients with HIV could potentially be put on azole antifungals. And we'll talk more about those when we talk about the opportunistic infections. Rarely, these medications can cause dermatologic adverse events or even manifest psychiatric concerns. Usually, the dermatologic events are not a big deal and you can treat through. You can continue to treat with an integrase inhibitor and the rashes will go away. Every so often, though, these can actually cause more severe ones like toxic epidermal necrolysis or Stevens-Johnson syndrome. So it's important to be careful watching those. When it comes to psychiatric concerns, oftentimes people who are well controlled on antidepressants or anti-anxiety medications will be fine. But every so often you will have somebody who has been on those medications and is suddenly showing signs or symptoms of their condition again. Similarly, you can see exacerbations of bipolar mania or schizophrenia. It's quite rare, but it can happen. And similarly, if we have members who have never had any of those conditions before and they start these medications, on very rare instances, you can actually see them manifest their first conditions or their first symptoms of those psychiatric concerns based on the fact that they're on this drug. Increases in LFTs are quite common with these medications, and one of the great things about this class of drugs is that of the third agents, this one tends to have the fewest amount of adverse events related to drug interactions. As a class effect, all of the drugs that we are dealing with do need to be taken cautiously with cations or di and trivalent anions, things like aluminum, magnesium, calcium, iron, zinc. The reason that this is important is because they actually chelate and make the antiretrovirals not work as well. So it's not a matter of stopping or choosing to use a drug that's not an integrase inhibitor. It's more a concern that you space them appropriately and you can get through that with no problem. So the first integrase inhibitor we will talk about is Raltegravir. Previously, this was given twice a day at 400 milligrams twice a day. Newer kind of formulations have suggested that there's a high dose or an HD formulation that is 1200 milligrams daily. And when done in head-to-head studies, what they found was that the 1200 milligrams daily of the high dose formulation was as effective as the 400 milligrams twice daily of the immediate and normal dose. This has only been studied with tenofovir disoproxil fumarate and emtricitabine, and there is some concern about the use of the Isentress HD in pregnancy. When we talk later, you will see that the twice daily Raltegravir is actually one of the preferred regimens for pregnancy, but the high dose is not, for the same reason that we're concerned about Dolutegravir, in that by the time the third trimester rolls around and we have somebody who is at increased volume of distribution, there's concern that the dose won't be high enough to keep the levels appropriate. Raltegravir is metabolized through UGT1A1 glucuronidation, which is a phase 2 type of metabolism. This does bypass any of the CYP enzymes, so it avoids a lot of the drug interactions that you'll see with other drug classes that we talk about. One drug interaction in particular that I do want you to remember, just because I'm also teaching you the TB lecture, is when you're using rifampin with Raltegravir, you're going to want to increase the dose from 400 milligrams twice a day to 800 milligrams twice a day. Adverse events are relatively rare with this medication. Some nausea, dizziness, and headache could happen, but these are self-limiting. And we talked about the psychiatric and the dermatologic conditions already. But now I want you to consider why this is not one of the drugs that is first line in the treatment of HIV in people who are not pregnant. One of the reasons is that there are other drugs that are available that are single tablet regimens, and this one does not have a single tablet regimen. The other concern is that in most cases, this is actually still used twice a day. And since all the rest are used once a day, this one tends not to be anybody's first choice. Now, as an example of a drug that does have a single tablet regimen and is used once a day, we have Elvitegravir, which is one of the integrase inhibitors available. Because it is boosted with Cobicistat, like many of our protease inhibitors, which we'll talk about in a little bit, are as well, this can cause GI upset and some bone and muscle pain. This is not related to the Elvitegravir, but is related to the Cobicistat that's boosting it. And currently, one of the only ways you can get this medication is with the Cobicistat on board. The booster can actually increase serum creatinine, but it's a false marker of renal disorder. Generally, when we look at serum creatinine and it starts to go up, we start to worry about their kidney function, and this is just an effect of the drug. If we were to do testing with inulin clearance or a 24-hour urine collection, we would see that the actual renal function is not going down, but the booster is having the effect on increasing the serum creatinine. Boosters, when we talk about protease inhibitors in just a bit, are, I guess, best known for the fact that they do cause drug interactions. So this is going to be a drug that does have drug interactions, just like our protease inhibitors will. And this one has to be given with food. Food will actually increase bioavailability of the drug, but also reduce side effects. There are 2 single tablet regimens available that concern this drug, and the only difference between the two is that one has the tenofovir DF, while the other one has tenofovir AF. Again, if you have a choice between DF and AF, you're going to always want to go with the AF, just in case you're trying to prevent any sort of long-term side effects. But neither of these drugs are considered first line. And the reason that neither of these is considered first line is that you are really concerned about the side effects compared to the other integrase inhibitors, and also the drug interactions. Dolutegravir is the third integrase inhibitor that's available, and this one is available not only as a single agent tablet, but also as a single tablet regimen. Most often this is going to be dosed once a day, but in people who have integrase inhibitor resistance or there's a concern about drug interactions, you can use it twice a day. The drug interaction potential is still relatively low, but it does have minor CYP3A metabolism, so this one has more drug interactions than Raltegravir, but fewer drug interactions than Elvitegravir. One drug interaction that I do want you to know is actually based on a renal transport protein and not the CYP enzymes, and that's because this one does inhibit OCT2. Metformin is also known to be transported with OCT2. So if you inhibit OCT2, you're getting extra metformin in your system. And one way to prevent the adverse events related to metformin is to ensure that the dose in these patients who are using both drugs is no higher than 1,000 milligrams of metformin a day. This drug can also falsely elevate the serum creatinine, just like the Cobicistat can. And this is now the new gold standard. So anytime a new drug comes out on the market for HIV, it is because it's gone up against this drug and has been shown to be non-inferior. So this one can be considered first line, and in most cases it is, but there is one group of people who shouldn't use this. And that group of people is pregnant women, or people who are about to become pregnant or are thinking about being pregnant. And again, the reason for that is that Dolutegravir in some studies has been shown to have or cause neural tube defects. And until we know more, we don't want to use it if there are other options available. And the last of the integrase inhibitors, another one of the first-line agents, is Bictegravir. Now, Bictegravir does not come as a single agent. It only comes in co-formulation with tenofovir, elafenamide, and emtricitabine. So this is only a single tablet regimen. And this is generally a pretty good thing, but there might be a bit of an issue when it comes to there not being a single agent. And my question to you is, what might that be? So the answer would be that if somebody were started on a Bictegravir containing regimen, which is combined with tenofovir, elafenamide, and lamivudine and emtricitabine, as their renal function starts to fall because of age or because of other issues, drug interactions, side effects, whatever it is, if the renal function starts to go down, you need to start thinking about the potential of dose adjusting the lamivudine and the tenofovir. So you can do that if you break this drug up, but the problem is you can't put them on Bictegravir because the single agent doesn't exist. So in those cases, you would have to probably throw them on the Dolutegravir because there is a single agent there. When it comes to drug interactions, again, all cations are possible. There are no food restrictions with this one. And when it comes to first-line agents, this is one that could be used in pretty much everybody. The one time you wouldn't want to use this one is when a person can't take tenofovir. And the only reason that's the case is that the only co-formulation available with Bictegravir is one that contains Dolutegravir as well. So recent evidence does suggest that the integrase inhibitors are preferred as the third agent. In all the studies that have been done, they show non-inferiority or even superiority to protease inhibitors and efavirenz, which is one of the NRTIs. When it comes to choosing between the two, Bictegravir is actually non-inferior to Dolutegravir, so they are similarly effective. Some benefits to the integrase inhibitors over protease inhibitors is that protease inhibitors have a lot of drug interactions, mostly because of their boosters. So most integrase inhibitors, with the exception of the one that's boosted, the Elvitegravir, don't have as many drug interactions as protease inhibitors do. Protease inhibitors, as a rule, also have effects on increasing blood lipids, increasing blood sugar, and potentially causing LFT elevations. Darunavir does come as a single tablet regimen, and we do use that drug, especially for people who can't tolerate integrase inhibitors or who are about to start rapid treatment. How integrase inhibitors are potentially better than NNRTIs, and we'll talk about these in a little bit, is the potential for drug interactions is higher with NNRTIs. Efavirenz has it increases triglycerides with long-term use, and it also has a lot of central nervous system effects. Rilpivirine can only be used in treatment-naive patients unless it's being used as part of Juluca in those treatment-experienced patients who have stabilized and are undetectable. This has to be given with people who have a viral load less than 100,000 copies and for CD4 counts greater than 200. It also needs acidity in the stomach, so there's some drug interactions to worry about. And because it does need food to be considered bioavailable, it has to be taken with a meal that has at least 500 calories. And Doravirine is relatively new. There's a bunch we'll talk about with Doravirine, but currently the only real benefit to this one is that it does come as a single tablet regimen, and people who are resistant to other NNRTIs can still use this one because it has a different resistance profile. So how do you choose between the integrase inhibitors? Well, in all cases, once daily is going to win out. So if we had the choice between Raltegravir HD and Raltegravir, we would use Raltegravir HD. But there is no single tablet regimen that contains Raltegravir, and you can't use the high dose Raltegravir in pregnant women. So single tablet regimens are always going to win out as well. So we've got the options of 3 single tablet regimens available. The reason Elvitegravir is not used is because of the drug interactions and the side effects, which tend to be a little bit more severe than the single tablet regimens that contain Dolutegravir or Bictegravir. When it comes to efficacy data, both Dolutegravir and Bictegravir do seem to be equally efficacious, so there's no concern there. So how would we choose between Dolutegravir and Bictegravir? We really have to consider any reason that these 2 agents shouldn't be used, and we also need to consider what NRTIs we're using. So like I said before, if you have somebody who can't take Abacavir because they have the hypersensitivity allele, or because they have a risk of cardiovascular disease in their family, you're going to throw them on Tenofovir. And Tenofovir is usually co-formulated with emtricitabine. And because you're talking about different single tablet regimens between the integrase inhibitor classes, the only one that is combined with tenofovir and emtricitabine is Bictegravir. So it's all based on your NRTIs. And similarly, if you have somebody who's got really bad renal function and you're concerned about using Abacavir, or you're concerned about using tenofovir, you'd use an Abacavir containing a regimen. Abacavir is combined with lamivudine as a single combination, but then as a single tablet regimen, Dolutegravir is combined with Abacavir and lamivudine. So that's how you choose between those 2. Quickly, we'll talk about protease inhibitors. The long-term effect of the protease inhibitor class is that it can cause fat redistribution and increase triglycerides. It can also increase blood glucose and insulin resistance. And as a class, these can also increase QT prolongation and act as blood thinners. So you have to be careful with interactions. You have to be careful about hemophiliacs and people who are already on blood thinners. These drugs are also, with the one exception of Darunavir, inhibitors of CYP3A. Lots of drug interactions with this class. And we have to consider not only the drugs that are kind of expected, but these drugs are also inhibitors of P-glycoprotein, which is going to cause its own interactions. The first one that's important to recognize is Ritonavir. We do not use Ritonavir as a full dose drug. The reason that I even bring this up is that if you were to try and look up the Ritonavir, the boosting dose that most people are going to be on in Hippocrates or clinical pharmacology or Lexicomp, the full dose is 600 milligrams BID. And that will come up, and a lot of times in ECMC, the students, the interns, the medical interns who are working on cases with our patients would see this as the dose, and they would actually try and get our patients to take this dose when they should have been taking a booster dose. Lots of issues with the full dose Ritonavir, including all sorts of really bad side effects. Some of them are listed here, and what I will say about the side effects is that oftentimes people would complain that everything they tasted, even when they weren't eating, their mouth tasted like they had copper pennies in their mouths. Another concern with long-term use is the buffalo hump seen in the middle. So there's a fat redistribution with these drugs that can actually lead to some pretty heavy concerns with cardiovascular issues and with cosmetic concerns. And the picture on the bottom is a picture of the fat redistribution as well. So increasing visceral adiposity is seen with full doses of Ritonavir. And if any of you have taken any sort of diabetes class or cardiovascular class, you know that that's the worst kind if there's concern about cardiovascular issues. The reason that the bus is up there is that we had a patient who had a developmental delay who was taking one of the medications but was being boosted on Ritonavir. He wound up being on a higher dose of Ritonavir because he was taking twice daily protease inhibitors, but he couldn't drive and he was trying to get to an appointment with his counselor, was taking the bus because that was the only way he had to get down there, and wound up standing in the middle of the bus, like this guy who is in that picture wearing the hat. Say it was one of those pictures. And he started noticing that he really had to go to the bathroom. He was noticing that he probably needed to get off the bus as soon as possible. But there was no way for him to get off the bus because he was in the middle of the bus, and he figured he would wait till the next stop and get off there. And of course, in Buffalo, where we see a lot of issues with potholes, As soon as the bus hit one, he lost control of his bowels and wound up having diarrhea on the bus. So just as an example of how bad that diarrhea is, a lot of people with protease inhibitors have such bad diarrhea that they don't want to leave their house because they're afraid of circumstances like that. So what is boosting? Well, first off, Ritonavir is a booster. It's taking small amounts of a drug and using it to inhibit the metabolism of other drugs. So with using Ritonavir as a booster, you have the ability to use higher concentrations of the other protease inhibitor with using less of the second protease inhibitor, and also this will decrease the dosing frequency. Most often, it's not 600 milligrams BID. The dose is 100 milligrams daily with every dose of the active protease inhibitor. So that's much less of the drug, which means there's much less risk of side effects. And the other booster is Cobicistat, which we kind of talked about with Elvitegravir. This has no activity against HIV, but it does inhibit CYP3A with no effect on other CYP enzymes. So there might be fewer drug interactions than with Ritonavir. Boosted protease inhibitors and integrase inhibitors, which we already talked about, there are two that are co-formulated with Cobicistat. One of them is Darunavir and one is Atazanavir. The side effects related to these are mostly GI related and bone and muscle pain. And again, that Cobicistat can cause a false elevation of serum creatinine. The two protease inhibitors that we're going to look at are Atazanavir and Darunavir. Atazanavir tends to have the best GI tolerance of all the other protease inhibitors, but it is related to a drug that can crystallize out in the nephrotubules. So making sure they're drinking a lot of water to keep the system flushed is going to be a good idea. This drug can also cause hyperbilirubinemia, which leads to jaundice and scleral icterus. And this is cosmetic, has no impact on the function of the liver, and once you stop the medication, it will go away. This has less effect on lipids and blood glucose than the rest of the protease inhibitors that are out there, but it does need acidity in the stomach to work, so you're going to need to be careful with acid blockers, proton pump inhibitors, and this will require dose adjustments and schedule changes. Another drug that is available is Darunavir, and this is used first line in people who are deep salvage, or in our current case, it's used as one of the options for rapid treatment of antiretrovirals. It has a very high genetic barrier to resistance, so it's the most forgiving of the drugs that we have available. And if it's used for treatment experience, it can be used twice a day, but so far in current treatment-naive patients, it tends to be once daily. It tends to be pretty good. There is one example where that's not the case, and we'll talk about it later, but for pregnant women who are using this as their drug, it has to be twice a day. This does contain a sulfa moiety, but so do other protease inhibitors. And one of the reasons I bring this up is that clinically, the sulfa does not have an actual clinical concern. So they've done studies with people who are given Darunavir who have allergies to sulfa and those who don't. And the likelihood of having the rash is just as common with those who have a sulfa allergy and those who don't. And when you compare those who are given sulfa in Darunavir as their HIV medication, or one that is given that doesn't have sulfa in it, the sulfa moiety doesn't impact the impact of the, or it doesn't impact the amount of times or the incidence of the rash. Pretty well tolerated. It does cause nausea and diarrhea, increased LFTs, headache and rash, and the one concern is that you want to make sure you're not using it if somebody has bad hepatotoxicity. Here are some other protease inhibitors that are listed. What I would say is, again, you don't need to know these, but they do show up on licensing exams, so this might be helpful in those cases, but do not worry about it for today. How do you choose protease inhibitors? Generally, they are not the first line recommended, with the exception of rapid initiation, in which case you're going to use Darunavir or Dolutegravir. The only two drugs that are currently used anymore are Atazanavir and Darunavir. Because of co-formulations, they are co-formulated with Cobicistat. Atazanavir has a low genetic barrier, so very few missed doses can lead to resistance, and Darunavir has a high genetic barrier to resistance. So in the option where you do need to use a drug that's not an integrase inhibitor, that Darunavir is probably your best bet.